Safety Lesson 8 covers pregnancy and radiation safety from two perspectives. First, imaging the pregnant patient. When is it safe? What are the risks? And how do you communicate with the patient? Second, the pregnant radiographer. What are your rights, your dose limits, and your monitoring obligations? This is one of the most emotionally charged topics in radiation protection, and one of the most heavily tested on the ARRT. 11 minutes. Let's cover it precisely and compassionately. The embryo and fetus are among the most radiosensitive tissues in existence. Rapidly dividing, undifferentiated cells in continuous high mitotic rate development. Radiation effects depend critically on dose and gestational stage. Pre-implantation, 0 to 2 weeks. All or nothing principle. High doses may cause spontaneous abortion. Surviving embryos typically develop normally. No documented teratogenic effect in survivors. Organogenesis, 2 to 7 weeks. Highest teratogenic risk. Organ systems are forming. Doses above 100 to 200 milligrams can cause major malformations. Most sensitive window, weeks 3 through 5. 8 to 15 weeks. Central nervous system development continues. Intellectual disability, microcephaly, and growth retardation possible above 100 milligrams. 16 weeks to term. Organogenesis largely complete. Malformation risk drops substantially. Growth restriction still possible at high doses. Stochastic cancer risk persists throughout gestation. Understanding dose thresholds allows you to counsel patients accurately and support clinical decision-making. Below 50 milligrams. No documented increase in congenital malformations or growth restriction above the background rate. The stochastic cancer risk increases slightly under the LNT model, but the absolute increase is very small. Most diagnostic imaging falls well below this threshold. Imaging is generally considered safe. 50 to 100 milligrams. Possible minor increase in risk. Benefit versus risk discussion with the referring physician and patient is warranted. Technique optimization is strongly recommended. Above 100 milligrams. Meaningful increase in risk of malformation, growth restriction, and central nervous system effects, depending on gestational age. Does not automatically indicate termination. Multidisciplinary consultation required. Above 500 milligrams. Major developmental abnormalities likely. These doses occur at therapeutic radiation levels, not from diagnostic imaging. Possible grounds for termination counseling in a multidisciplinary setting. Critical fact: most diagnostic imaging delivers well below 50 milligrams to the fetus. A chest X-ray delivers less than 0.01 milligrams. A CT of the abdomen and pelvis, 8 to 25 milligrams. Two non-negotiable foundations for imaging a pregnant patient. First, never withhold medically necessary imaging solely because of pregnancy. A pregnant patient with a suspected pulmonary embolism, acute abdomen, or traumatic injury needs the same timely diagnostic workup as any other patient. The risk of an undiagnosed condition typically far outweighs the fetal radiation risk from diagnostic imaging. Second, always ask. The current standard is the 28-day rule. Ask every patient who could possibly be pregnant before any pelvic or abdominal exam. The older 10-day rule has been replaced. If pregnancy is confirmed or possible, consult the referring physician. Consider ultrasound or MRI first when clinically appropriate. Neither uses ionizing radiation. If X-ray or CT is necessary, proceed with a low-dose protocol. Increase kVp and reduce MAS. Collimate tightly, shield the uterus when it's outside the field of interest. Document the clinical justification, technique, and estimated fetal dose in the radiology report. A pregnant radiographer has specific rights under federal radiation protection regulations and employment law. Declaration of pregnancy is always voluntary. It must be submitted in writing to activate regulatory protections. A verbal statement alone does not count. The worker may also rescind, withdraw, the declaration in writing at any time. Once declared in writing, NRC 10 CFR 20.1208 establishes the fetal dose limit. 5 millisieverts for the entire gestation, with a monthly limit of 0.5 millisieverts. The employer cannot terminate, demote, reduce pay, or punitively reassign a worker for declaring pregnancy. The Pregnancy Discrimination Act, PDA, protects against these actions. The worker may request reassignment to lower dose work. The employer must make reasonable accommodations. High-dose assignments, fluoroscopy, interventional work, nuclear medicine isotope handling are most likely to be modified. A fetal badge must be provided. It is worn at waist level under the lead apron at all times while working. After a written pregnancy declaration, a fetal monitoring badge is assigned separately from the primary badge. It is worn at waist level under the lead apron, approximating the dose at the fetal location. It is not identical to the actual fetal dose because maternal anatomy, uterine position, and gestational age all affect the relationship between badge reading and actual fetal dose. The badge should be read monthly, or more frequently, after declaration. If the monthly reading approaches 0.5 millisieverts, the radiation safety officer must review the assignment and make modifications immediately. For a patient receiving direct pelvic irradiation, a medical physicist estimates the fetal dose using technique factors and published dose tables. NCRP Report 54 provides the methodology and reference tables for fetal dose estimation. 6 communication principles for radiation and pregnancy. Ask every time. Is there any chance you could be pregnant before any pelvic or abdominal exam? Ask even if the patient seems unlikely to be pregnant. Explain the actual risk in plain language. Most diagnostic X-rays deliver a very small amount of radiation to a developing baby, much less than what would cause harm. Provide context. A chest X-ray delivers about the same radiation as a few hours of natural background radiation from our environment. Context reduces unnecessary fear. Never withhold emergency care due to pregnancy. If you need this imaging to diagnose an emergency, the risk of not knowing is greater than the small radiation risk. This is the clinical and ethical standard. Document it clearly. Document everything. The question was asked, the patient's response, the clinical justification for proceeding, the estimated fetal dose if pregnancy is confirmed, and refer for counseling when needed. If the dose was significant, or the patient is distressed, refer to the radiologist and OB/GYN for counseling. Do not make final risk assessments yourself. Knowing approximate fetal doses allows accurate patient counseling and clinical decision support. Chest X-ray PA and lateral, less than 0.01 milligrays, essentially negligible. The uterus is far from the beam. Abdominal X-ray AP, 1.4 to 3.0 milligrays, low, well below threshold. Lumbar spine AP and lateral, 1.7 to 10 milligrays depending on technique. Optimize and document. Pelvis X-ray, 1.1 to 4.0 milligrays. Collimate tightly and shield when the uterus is outside the field. CT head, less than 0.01 milligrays, negligible. CT chest for pulmonary embolism protocol, 0.06 to 0.96 milligrays. Very low, appropriate for emergency indication. CT abdomen and pelvis, 8 to 25 milligrays. Use a low-dose protocol. Justify the indication clearly. Barium enema and lower GI, 1.1 to 5.8 milligrays. Use reduced fluoroscopy time aggressively. Nuclear medicine bone scan, 4 to 5 milligrays. Consider MRI as an alternative when clinically feasible. Interventional fluoroscopy, highly variable, potentially several gray. Consult a medical physicist for case-specific estimation. 3 pregnancy and radiation questions. These require careful reading. Details matter. The answer is C. A written declaration is required to activate the 5 millisievert gestational limit, and verbal declaration is insufficient. Under NRC 10 CFR 20.11208, a declared pregnant worker is specifically defined as someone who has voluntarily submitted a written statement of pregnancy. A verbal notification does not trigger regulatory protections or the dose limit change. The fetal badge must be worn under the apron at waist level, not outside it. The answer is C. Perform the exam using a low-dose protocol and document the estimated fetal dose. Emergency imaging is never withheld solely due to pregnancy. At 6 weeks gestation, the embryo is in the period of organogenesis. A CT of the abdomen and pelvis for suspected appendicitis typically delivers 8 to 25 milligrays, well below the 50 milligray threshold for low risk. Use a low-dose protocol. Involve the radiologist and OB/GYN in counseling. Document the clinical justification. The answer is B, 5 millisieverts, 0.5 rem, for the entire gestation. This is the NCRP fetal dose limit established in NCRP Report 116 and enforced through NRC 10 CFR 20.1/2008. There is also a monthly limit of 0.5 millisieverts to prevent concentration of dose in a single month. The 50 millisievert limit is the annual occupational whole body limit for non-pregnant workers, not applicable to the fetus. The 0.5 millisieverts per month is the monthly limit, not the total gestational limit. You've completed the pregnancy and radiation safety lesson, and the entire safety category. You covered gestational stage radiosensitivity, fetal dose thresholds, the framework for imaging pregnant patients, occupational declaration rights and dose limits, fetal dosimetry and badge mechanics, patient communication principles, and a fetal dose reference table. Head to the practice section and keep drilling before your exam. Quick reference card. All 16 lessons. Print this and keep it at your recording desk. File 1. Lessons 1, 2, 3. L1, Ethics and Legal, about 10 min. L2, Communication, 5 min. L3, Patient Transfer, about 5 min. File 2. Lessons 4, 5, 6, L4, Vital Signs, about 5 min. L5, Medical Emergencies, about 6 min. L6, Contrast Media, about 6 min. File 3. Lessons 7, 8, Safety. L7, Infection Control, about 6 min. L8, Hazardous Materials, about 4 min. S1, Radiation Physics, about 12 min. File 4, Safety, 2, 3, 4. S2, Biological Effects, 15 min. S3, ALARA and Personnel Protection, 10 minutes. S4, Minimizing Patient Exposure, 14 min. File 5, Safety 5, 6, 7. S5, Exposure Monitoring, with 10 minutes. S6, Protective Shielding, 12 min. 7. Fluoroscopy Protection, with 16 min. File 6. Safety, 8. S8, Pregnancy and Radiation, Safety, 11 min words. Bill should say slowly every time. Bremstrahlung. Bremstrahlung respondit superior. Respondi et super e or res ipsa loquitur. Res ip su loquitur bergonier. Bergoniae tribando. Tribondioh hematopoietic. Hematopoietic organogenesis. Organogen cis microcephaly. Microcephaly erythema. Erythema desquamation. Desquamation teratogenic. Teratogenic stochastic. Stochastic deterministic. Deterministic gadolinium. Gadolinium fluoroscopy. Fluoroscopy fluoroscopic. Fluoroscopic thermoluminescent. Thermoluminescent scintillation. Scintillation kerma. Kerma vasovagal. Vasovagal anaphylaxis. Anaphylaxis extravasation. Extravasation syncope. Syncope diaphoresis. Diaphoresis cytotoxic. Cytotoxic glutaraldehyde. Gluta. Ralde. Hyde nosocomial. Nosocoh meal thermionic. Thermionic photoelectric. Photoelectric gestation. Gestation microcephaly. Microcephaly abbreviations. Always spell out on first use per lesson. ARRT. ARRT. HIPAA. HIPAA. ALARA. ALARA. NCRP. NCRP. KVP. KVP. MAS. MAS. MSV. MSV. MGY. Milligrays. SID. SID. TLD. TLD. OSL. OSL. EPD. EPD. DNR. DNR. CPR. CPR. AED. AED. PPE. PPE. EHR. EHR. OSHA. OSHA. GHS. GHS. SDS. SDS. AEC. AEC. LNT. LNT. NRC. NRC. FDA. FDA. RSO. Radiation Safety Officer. HVL. HVL, TVL, TVL, PBL, PBL, CAP, KAP, ERCP, ERCP. End of registry-ready narration scripts. All 6 files. Voice, bill. Platform, 11 labs. Lessons, 16 total. Total estimated runtime, 132 minutes across all lessons.